Thank you everyone for being with us today, and we might get started since we've got all our finalists, judges and a number of audience members on the line. So my name is Hilary Murchison and I am a committee member with the Students and Young Professionals in Public Health Committee within the Public Health Association of Australia. So I would like to start by acknowledging the traditional owners of the lands on which we live and work. We're joined by people all over today, so lots of different lands, and we acknowledge the traditional owners of all of those and pay our respects to their elders past and present. So it gives me a lot of pleasure to welcome you all to our webinar today. As I said, we've got our finalists, we've got our judges, and we've got a number of audience members. So it's wonderful to have you all with us and supporting this competition, the think tank competition, and also supporting the activities of the Students and Young Professionals in Public Health Committee and the Public Health Association of Australia. Before I go too much further, just a bit of housekeeping. I'll just ask that anyone who is not speaking or presenting, that you mute your microphone, and if all audience members could switch off their video sharing, please, just to help things run nice and smoothly. So yeah, as you're all aware, we are here today as part of the National Public Health Student Think Tank competition for 2018. And this competition has been an initiative of the Students and Young Professionals in Public Health Committee. And as I said, you'll hear a bit more about the committee later on in our webinar. But for now, I'll just give you a quick rundown on the competition as it stands so far. So the think tank competition launched in May. And the idea was, we really hoped it would be a way to engage the student audience in the public health field, as well as give them a chance for exposure to engage with the field and capture their energy, because we all know students have a lot of energy and innovation for their field. So students first entered by providing a written response, and the prompt for that response was to describe an unmet need within the field of public health and describe how public health leadership is needed to address it. So we received a really quite overwhelming number of entries, which we're really pleased with. And these were then reviewed according to our predefined set of criteria. So this included demonstrated understanding of public health principles, it included critical thinking, innovation, feasibility, and appreciation for the capability of public health leadership. From this, our top 4 shortlisted entrants were invited to develop their response into a presentation of no more than 7 minutes, and that's what we'll be hearing today. So that competition prompt, by tying in with public health leadership, was actually designed to tie in with the Australian Public Health Conference theme for 2018, and that theme is Leadership in Public Health, Challenges for Local and Planetary Communities. And the reason for this is that our winning finalist from today will actually go on to present their response at the conference in the closing plenary session. And our winner will be receiving free registration to the conference and a significant contribution to their flights and accommodation. And it's with great thanks to the PHAA that we are able to offer this wonderful opportunity. So I'd like to thank them again, not only for their support of the think tank competition, but also their dedication to supporting students and young professionals in public health. And I would like to give a special welcome and thanks to our judging panel for today. So we are very pleased to have a really high level of expertise with us to be reviewing our finalists. So this is made up of PHAA CEO Terry Slevin, who most of you would have heard speaking a moment ago. We've also got Paul Gardner, who's the co-chair of the Australian Public Health Committee for 2018. And Amy Brownbill, who is the chair of the Students and Professionals in Public Health Committee. So I think I've covered everything, and with that we might launch into our entrants. Before I do, if there's anyone that has joined us just in the last couple of minutes, welcome firstly, and can I just ask that you mute your audio and turn off your video sharing if you're an audience member, just to help things run smoothly. So each of our entrants will have no more than 7 minutes to present their responses today, so I'll be keeping an eye on the time. After that, there'll be an opportunity for our judges to ask 1 or 2 questions, before we move on to the next entrant. So judges, I'll just ask you to use the raise hand function to let me know that you have a question for that finalist. So I'll start by introducing our first finalist, Cassandra de Lacy-Vorden. So Cassie is a PhD candidate at Monash University in Victoria, and she'll be presenting on the topic, considering the commercial determinants in all aspects of public health. So Cassie, are you there and you're right to get started?
I'll just bring up my...
No worries. But yeah, I'll just be keeping an eye on the time, Cassie, and I'll let you know when you've reached your 7 minutes.
Brilliant, thanks Hilary. So we'll be talking to you today about the commercial determinants of health within public health. And first of all, as is quite important in this field, in the interests of transparency, here are my past and present funding arrangements, but most importantly, I don't work for anyone that would be benefiting from this research. So the social determinants of health are familiar to us all now, thanks to the work of Marmot and colleagues. And for several decades, the social determinants of health have been embedded within the work and practice of public health professionals. However, this increased consciousness and effort has not yet led to those wide-ranging increases in public welfare as we'd initially hoped. And there is now a greater burden of disease from non-communicable diseases than ever before. For exceeding the good work of public health professionals the world over are these corporate interests and the act of those corporate interests. The tobacco industry, alcohol, mining, things like fast food and processed food and beverages, gambling, pharmaceuticals, things like the automotive industry, firearms, and many more have been working to maximise profits, and that often comes at the expense of public health. When considering that 69 of the world's top 100 corporations, top 100 economies are now corporations, that's the impact on health is fairly easy to understand. However, we've not been overly good at recognising that impact on health, and instead we've focused on individualisation and unhealthy lifestyle factors. We've partnered with these industry organisations and we've often taken their money. And in recent years, this has led some to turn their attention towards what are now called the commercial determinants of health, or those strategies and approaches used by the private sector to promote products and choices that are harmful to health. We can think about the commercial determinants as a separate set of determinants that operate in parallel to the social determinants and affect all aspects of health. They're driven by factors such as internationalisation and corporate growth and expansion, and we see them reflected in things like trade relations, the outsourcing of labour to countries with lower wages and fewer worker protections, and the multinational corporates that often move their profits offshore to avoid taxation. We see them channelled through things like corporate citizenship that afford corporates greater rights than individuals or governments. We see them channeled through marketing and advertising that on the one hand will tell us to consume more and buy more, and on the other hand will tell us things like drink responsibly, consume within a healthy, balanced lifestyle, or gamble responsibly, all the while shifting the blame away from industry and positioning industry as part of the solution. We're seeing them through vertically integrated supply chains, controlling all aspects of production through to sales, and we see them operating through corporate political activities such as lobbying, donations, and the like. And the outcomes of all of this are, in general, environmental degradation, overconsumption, and a general erosion of health and well-being. So the actions of those corporate and commercial interests are consistently at odds with public health. And for the most part, those behaviours go unchecked. But that's where we come in. As public health professionals, we're primed to protect and promote population health. And whilst the commercial determinants of health might seem like a wild and possibly untamable beast, and whilst addressing them would require significant political intervention and possibly reorientation, there are small things that we can do in our everyday work to minimise their effect on health. First and foremost, that means checking corporate behaviours. As I said, they're currently going unchecked and we're probably best placed to fix that. So that means being educated and alert and being as conscious of the commercial determinants of health as we are of the social determinants of health. But it also means researching, documenting and building an evidence base from which to examine corporate practices and health outcomes. Practically, that translates into considerations for partnerships and funding in particular, and within consultations, programming and research, and being critical of the influences upon our own and upon others' work. The best example of where this has already been successful is probably the tobacco industry, who were once big funders of research and corporate social responsibility activities in Australia, but that's almost unimaginable within the current environment. And that was brought about largely by painstaking documentation, evidence building, until the case against them was undeniable. So to check corporate power means to examine things like the food industry's involvement in sports sponsorship and physical activity research, or the gambling and alcohols industry involvement in sports sponsorship and sporting programs. And whilst that requires more than checking and minimising those vested interests, that's probably a good place to start. Secondly, we need to reorient our public health efforts towards addressing the commercial determinants at the centre of many public health challenges. This involves moving away from industry-favoured language, emphasising personal responsibility and calling out those underlying determinants. If not, we're only doing the industry's job for them. So we need to dispel the doubt, as was done with tobacco, and more accurately capture and describe the harms associated with these industries. And that might also mean we have to look at industries traditionally considered benign and reevaluate them within a commercial determinants of health framework for previously unconsidered harms. And finally, and perhaps above all, we need to be advocating for more ethical corporate practice for the betterment of public health. And this also means advocating for better policies and greater transparency to identify where unethical practice is occurring. To do this effectively, we need to seek greater involvement in policy processes and to use evidence of harms to advocate for greater population protections from corporate interests, and to learn from industry tactics to be proactive in our approach. This is something that can be done at all levels of public health, whether internally, for instance, within a single organisation, department, project or team, or it could be done externally, such as to a politician or the media. So whilst the commercial determinants present one of the most pressing health challenges of our times, and a failure to address them is likely to lead to ever worsening health outcomes, there are practical things we can do. So by checking that corporate influence, by acknowledging the commercial determinants at the centre of our work, and by being advocates for more ethical practice and policy that requires that, we can begin to change that. Thank you.
Thanks very much, Cassie. Excellent to hear from you. And we'll just turn now to our judges to see if they have any questions for you. Terry, Paul or Amy?
Terry, you're still on mute.
Oh.
Can't hear anything, sorry.
Terry, again, you're still on mute.
Okay. Oh, sorry. There you go. I'm a new boy at driving this beast, okay, so forgive me. Sorry. Cassie, thank you for that. My question to you is the interpretation of how we might advocate for that ethical practice in the boardroom. So do you have any recommendations about mechanisms that might systematically improve that practice in corporate boardrooms?
In corporate boardrooms, I think it's, it's a mixture of things. A part of that is applying, I think, that public health pressure, and I think the way we can do that best is by being really on top of having those documented harms and leveraging those harms to advocate for, to create the environment where really the best things for corporations in terms of their image and brand is to really start to address those those harms properly. I think that would probably be the best place to start in terms of that.
Okay, thank you.
Thanks, Terry.
Thanks, Cassie. Paul or Amy, did you have anything you wanted to add?
Yeah, Cassie, great presentation. I was just wondering what your thinking is around not so much targeting the companies and the corporations, but looking at the shareholders and, you know, trying to influence the companies through that mechanism.
I think that's a great point there, because essentially at the heart of the corporate is that they serve their shareholders, and that often means that they're not necessarily accountable to the general public in terms of ethical practice. They're accountable to their shareholders in terms of maximising profits. So that could definitely be a good place to be targeting those messages around harms and around the need to reorient towards that ethical practice.
Excellent. Thanks, Cassie. Thanks so much for your presentation. And we might move on to our second finalist. So our second finalist is Olivia Di Prospero. And Olivia joins us from Western Australia, where she's an undergraduate population health student from the University of Western Australia. Olivia will be discussing the topic of improving oral health in Aboriginal peoples. So thanks, Olivia, and feel free to get started when you're ready.
All right. Does that work? Does that sharing?
Yes, that's perfect.
Okay, cool. So dental disease is generally viewed as being largely preventable, yet Aboriginal peoples experience it more frequently than non-Aboriginal people. Despite recent efforts completed under the Closing the Gap framework, it's still necessary to acknowledge the disadvantage and intergenerational trauma experienced by Aboriginal peoples when examining Aboriginal health today. Ooh, there we go. Oral health in Aboriginal peoples is self-reported as being important, yet is frequently compromised due to factors influenced by policy, organisational practices, limited education about prevention, prohibitive costs, high exposure to sugary products, and discrimination. Research shows that Aboriginal children are twice as likely to experience dental decay and at a greater level of severity in both deciduous and permanent teeth when compared to non-Aboriginal children. This remains true even when rurality and social disadvantage are accounted for. So, poor oral health is the presence of caries or periodontal disease. The behavioural risk factors for oral health are excessive and frequent consumption of sugary food or drink, limited access to fluoridated water, tobacco use, consuming acidic beverages, and insufficient brushing or flossing. Other determinants are social status, education, environmental factors, and previous experiences with dental care practitioners. So experiencing poor oral health can have a huge impact on well-being. It influences physical appearance, speech, diet, taste, social life, and feelings of one's own personal well-being. Experiencing pain or discomfort can lead to missed days at school or work, disrupted eating and sleeping, hospitalisations, high treatment costs, poor nutritional uptake, and disrupted metabolic processes. Children who have been identified as having a poor oral health status have been shown to be more likely to miss school due to pain, and they tend to perform poorer academically. Oral health is directly related to other health outcomes, chronic disease, disability, and general health problems that may cause or worsen poor oral health. This is often due to the sharing of common risk factors between oral health and other general disability. So oral health is such a broad health issue, but it has the potential for public health leadership to target some of the problems in the following ways. Public health leadership is essential to address the barriers to good oral health that have been identified by Aboriginal peoples during focus groups. Policy change to improve access to oral health services is needed. While Medicare covers some emergency and childhood dental, often access to general dental care is not possible for many due to the associated costs. An access scheme similar to the pharmaceutical benefits scheme, allowing those fitting a criterion to be able to access general dental through concessional co-payments, is a step towards making oral health a realistic priority for many Australians. Prevention is key, so it is important for Aboriginal peoples to be able to access the preventative care provided during general dental checkups. If general dental becomes available to more citizens, it must be ensured through public health leadership that services are culturally appropriate. Implementing community-led collaborative oral health services in Aboriginal communities has received past feedback that services are respectful of Aboriginal heritage and culture. Involving Aboriginal communities through consultation and collaboration has been cited as the primary reason for success of previous health interventions in such communities. It ensures that the experiences of the community are heard and that they have the opportunity to actively involve themselves in every step of the process. Community involvement with Aboriginal peoples has been inconsistent in the past despite evidence of positive outcomes. Further collaboration with Aboriginal liaison officers can help to ensure Aboriginal peoples have access to appropriate services, while the introduction of translators like Aboriginal Interpreting WA has done in hospitals in far north of Western Australia will help to improve patients' relationships with dental care providers. Public health leadership has been implementing in-school healthy eating programs globally, which has created an increase in food literacy in both students and parents. A study based in an Aboriginal First Nations school in Canada, where children consumed the vegetables they grew at school, showed an increase in preferences for fruit and vegetables. However, this self-reported dietary behaviours did not change at home, and it was strongly suggested that family participation and community involvement was needed for this to happen. If similar programs are implemented in schools with an Aboriginal student population in a way that makes a connection between diet and oral health, and perhaps introduces behaviours such as how to brush teeth, then children and parents will be given the opportunity to make educated decisions about how they influence their own oral health in their future. These programs also have the potential to break down the common idea in Aboriginal populations that experiencing poor oral health is normal. Good oral health is an important aspect of overall well-being. However, it is an area of unmet need in Australia within the Aboriginal populations. Prohibitive costs, a lack of culturally appropriate services, and an absence of prevention education are just some of the areas where public health leadership is needed to create change. The literature I reviewed was largely specific to Aboriginal peoples, which is why I have made no reference to Torres Strait Islander peoples. However, this presentation is likely to be relevant to both populations. This is an area of health I'm particularly passionate about, and I know that through public health leadership, it is possible to improve the oral health of Aboriginal peoples. This will be another step towards better health and wellbeing in Australia, less financial strain on the health sector, and another step closer towards closing the gap. Thank you.
Thanks very much, Olivia. And we will now turn to our judges. Do you have any questions for Olivia?
Amy going first.
Oh, there we go. Sorry, I was having trouble trying to find my unmute button. I love that you've listed 3 examples of where public health leadership can be shown. I'm just wondering if you can give some more specific examples of what public health leadership may look like amongst any of those approaches, such as you've suggested reducing costs. Like how may we show public health leadership in that specific area, maybe advocacy?
Sorry, big trucks just give me past. What was the last little bit?
Just if you have any practical examples of how we can show public health leadership.
Yeah, I think, well, using the example, for example, of the healthy eating in schools, I think just by getting, I think the biggest problem with oral health in Aboriginal peoples is that it's not identified amongst the broader community as being the #1 problem. So I think by setting up small projects to sort of slowly introduce it and show the benefits, and therefore getting public health leadership directly involved in those in that manner, then I think it can slowly expand to become, you know, a nationwide, I guess, through policy and such approach.
Thank you.
Thanks, Olivia. Terry or Paul, did you have anything to add?
Another really good presentation, Olivia. Maybe give some examples of who you would think would be suitable public health leaders in... Am I muted?
No, I can hear you.
Right, okay, good. I just got a message. If you could give some examples of who you think would be suitable public health leaders to tackle poor oral health in these communities, and you know what sectors you think might come into play.
Yep. Well, obviously involving the Aboriginal or wider Indigenous population, it would be necessary to involve current Aboriginal and Torres Strait Islander public health leaders. They don't necessarily have to be the key stakeholders and roles, but they have to always be advising, of course. And I think going into specific sectors, I think it's something that can be tackled from all angles because there are so many risk factors towards poor oral health. So, you know, it can be direct from, you know, the dentistry side of things, or it can be from the broader, like looking at people nutrition, or people just in the broader government public health sector who cover just policies within at a federal level or state. I think it's something that has a potential to be tackled from all angles. I don't think it's something that should be looked at just from a few different areas. Yeah.
Good, thanks, Hilary, because Amy essentially asked the question I was going to ask. Olivia, thank you for that. What I'm going to invite you to do is give thought to the question, if you're in an elevator with the Minister for Health and it's going up 5 floors, what are you going to pitch for? What are you going to ask?
I think, to be honest, before taking a step towards actively addressing this problem, you know, by rolling out things in communities, I think, honestly, I'd probably just ask for greater recognition of the fact that it is a big problem and that it needs to be recognised by the wider public. So, you know, setting up not so much education, but just advertising, like promoting the fact that this is an area that needs to be addressed. And I think that's important to be done before we start, you know, going into communities and saying this needs to be changed and we're going to start implementing this and all that sort of stuff. Because having talked to a lot of health professionals, not people in public health, like doctors and such, they often have mentioned that oral health isn't an area they've really thought about addressing in the Aboriginal population in the past. So I think that's a big thing.
Thank you.
Wonderful. Thanks so much, Olivia. That was very interesting. And yeah, hopefully the judges got their questions all covered off. So we might move on now to our third finalist. So introducing Simone McCartney. And Simone's a PhD candidate at Deakin University in Victoria. So her presentation today is titled Moving Knowledge to Action, the Need for Knowledge Translation in Public Health. So Simone, whenever you're ready.
Thank you, Hilary. I'll just share that. All right, so good morning. I'm Simone McCarthy, and my presentation is titled Moving Knowledge to Action, the Need for Knowledge Translation in Public Health. I'm a PhD student at Deakin University and work in the Gambling Harm Prevention Unit, undertaking research on the impact of gambling in our communities. So in this presentation, several of my examples are drawn from this research area. So knowledge translation is an interactive process involving exchanges between researchers who create new knowledge and those who can effectively use it. However, health research often fails to translate research findings into practice and policy. It is vital that researchers use knowledge translation to ensure that evidence-based knowledge informs decision-making. Through knowledge translation, the benefits of research are accelerated. The healthcare systems and health services are strengthened, and there's a greater potential for positive outcomes for our population. Central to all knowledge translation strategies is the need to consider stakeholders who benefit most and can utilise knowledge. Knowledge translation must therefore become an integral part of research, where researchers value an integrated approach with policymakers and key stakeholders. This requires effective communication between those producing the knowledge and those implementing evidence-based practice and policy. Within gambling research, we are currently working closely with local councils to minimise gambling harm. The councils have been involved from the beginning, including project design, constructing interview questions, and final knowledge translation workshops that aim to understand how our research findings can be applied in the local context. Knowledge translation frameworks emphasise the critical need for stakeholder engagement at all stages of research to co-produce evidence that shapes and ultimately informs policy and practice. This enables researchers and key stakeholders to exchange knowledge and ideas and ensures that timely research is conducted that is relevant to the community. Involving key decision makers in the research process means that findings are relevant and can lead to evidence-based policy change. However, it is important to recognise that co-producing research may not always be appropriate. For example, researchers should not collaborate and co-produce research with industries such as tobacco, alcohol and gambling. Previous research indicates that their involvement has been used to create doubt and divert attention from product harm and can create favourable policy environments for these industries to maximise their profits. Instead, future research should employ strategies to develop independent evidence that enhances collaboration with stakeholders without conflicts to bridge this gap between research and action. Effective knowledge translation for public health researchers involves tailoring and synthesising key messages for different users, such as the public, practitioners and policymakers in language that can be easily understood. Further, methods of dissemination should be modified to better reach those who would most benefit from the research. This means moving beyond traditional routes of dissemination, such as peer-reviewed journals, to using multiple communication channels, such as active communication with the media and workshops and seminars with key stakeholders. An example of knowledge translation used effectively to inform policy change was from the recent ban of gambling advertising during live sport. Following research that found advertising a key influential factor of young people's intentions to gamble, a variety of messages were constructed to reach different audiences. These were disseminated via publication in a peer-reviewed journal, as well as through various media outlets and in a school-based newspaper article that targeted young people in Australia. These messages were further used in government advertising campaigns to advocate against gambling advertising. The success of this knowledge translation is evident as it sparked a discussion about gambling advertising, which gathered support from key influential stakeholders, including politicians. Community support for regulation led to an initial ban of gambling advertising near schools, roads and public transport by the Victorian government, with Premier Daniel Andrews citing the research findings as the critical reasons for this policy change. With continued community and political support for regulation, this led to the introduction of a national ban of all gambling advertising during live sport. This is one example of the power of effective knowledge translation. However, there are considerable barriers to implementing knowledge translation into research practices. For example, time and resources are needed to involve a range of stakeholders into research, and there is often little incentive for researchers to dedicate their time. For example, while the greatest impacts to society from research are studies that contribute to changes in practice and policy, these do not necessarily contribute to academic metrics. With universities fixated on grant funding, publications, and citation outputs, communicating research findings with media, communities, and organisations that impact policy and practice is often not recognised in academic promotion. Therefore, we must challenge the universities to include metrics that acknowledges these contributions to policy and practice to further encourage researchers to engage in knowledge translation. Leaders in public health should advocate for knowledge translation as part of the research process. Methods of knowledge translation should be built into the research plan from the outset, including involvement of stakeholders throughout the research project. Funding bodies also play a critical role in encouraging knowledge translation and should ensure that this is a priority in the research that they fund. This will be vital in a comprehensive strategy to ensure that research contributes to positive outcomes in public health. There is a role for public health leaders to implement strategies that address these gaps within their own work. Collectively, efforts need to be made to put scientific knowledge into action and ensure widespread implementation of evidence-based programs, practices, and policies. This must start with us, and it must start right now. Thank you.
Thanks, Simone. That was great. And we'll give our judges a chance for some questions now.
I'm happy to go first. Thanks, Hilary. Simone, thank you for that. Very thoughtful presentation. My question to you is, how do you wrestle with the financial influence of the gambling industry, given that the primary vehicle for controlling or minimising the adverse effect of the gambling industry is the same government that receives a substantial proportion of its revenue from that industry? How do you tackle that nexus?
Yeah, no, I think that's a really good point you're making, and it's definitely a challenge for everyone working in gambling. I think we do need to show that we're in support of not having these industries, having influence by funding, and we need to get funding from elsewhere. Yeah, we just need to show that we're not willing to work with the gambling industry and show governments that, like, community support for governments not taking revenue from gambling products.
Thank you.
Paul or Amy, did you have anything to add there?
Another really interesting presentation. Are there any examples that we can learn of from countries that are doing this well?
Not that I can't really answer that right now, but I know there's definitely other industries that are doing this really well. And I was thinking about disability. They do such great work at incorporating all people with disability in their research, and they make sure that they're a part of the research and disseminating to people with different disabilities so they can understand the research and they can use the research. So there's definitely evidence from other industries, and I'm sure there's different countries that have better translation processes. But yeah, we can definitely learn from other people. Yeah.
Yeah, Paul, thank you. That was the question I had as well.
Wonderful. Well, thank you very much, Simone, for that. And we will move on now to our fourth and final finalist. So I'd like to introduce Rosemary Weiber. So Rosemary is a PhD candidate at the George Institute for Global Health in New South Wales. And she'll be telling us her thoughts about why Australia needs a PBS process for Aboriginal and Torres Strait Islander health programs. So Rosemary, are you right to go?
Thank you so much. This is really exciting. This is certainly, I'm normally based at the George Institute for Global Health in Sydney, but I'm calling in my other research home at Telethon Kids Institute in Perth in Western Australia. So I'd acknowledge the Noongar Whadjuk people of this country and their elders past, present and future. And I guess I'd also ask you to cast your mind back to the 2018, all of it, and particularly the $3.9 billion allocation to Aboriginal and Torres Strait Islander health programs. The budget this year really contained a whole lot of line item details. So a focus on specific diseases, $34 million for preventable hearing loss, $30 million for eye checks, $4 million for crusted scabies. It's clear that particular programs and conditions and focus areas get prioritised in funding allocations, and they become a core part of the government's priorities. So I've really become quite interested in what that process is and how we can help support not just the government, but Indigenous communities themselves to make evidence-based and well-supported decisions about what should be prioritised and what should be funded. I guess I've come to that thinking from a couple of different ways.
Sorry, Rosemary, just sorry to interrupt you. Just before you keep going, would you mind just speaking up a little bit? You're just a little bit quiet.
Hello, yes, of course.
Thank you.
Look, my PhD is really focused on developing an end game for rheumatic heart disease in Australia. And that's a condition that affects predominantly Aboriginal and Torres Strait Islander Australians. And we are working through a Centre of Research Excellence to develop a set of costed stepwise recommendations about preventing new cases of rheumatic heart disease by 2031. And inevitably, my thesis and our end game will culminate in a report to government about what it is we think that they should do. And as part of that, I've been looking at the recommendations developed by other conditions and disease communities in Indigenous health to really figure out what those essential components of a report to government might look like. And what's become increasingly clear to me is that there really isn't an agreed template for that. So some of these roadmaps include narrative overviews, some have cost of illness studies, some have cost effectiveness studies. There's a whole different sets of data that are informing this decision, but they don't necessarily all match up or compare like with like. Similarly, the other thing that really leaps out as I read them is how glossy and well produced they are. So increasingly there's personal narratives and infographics and snapshots and media grabs. And those things are great because they make reports which would otherwise be pretty dry a little bit more readable, but they don't make them comparable. And so it's become quite clear that there's a whole lot of information flowing into government and decision-making bodies that isn't really easy to reconcile. My interest in this is literally academic, and so I get to read with interest. But if these reports were coming to me to decide what to fund, I don't think I'd know where to start, and it's not clear to me how the government, or anybody else for that matter, makes trade-offs between one kind of investment and another. I guess the other thing that's kind of informed my thinking about this is the media attention on Indigenous health priorities this year, and specifically the case of HTLV1, which is a carcinogenic retrovirus endemic in Aboriginal communities in Central Australia. In May this year, in mid-May, the Guardian Australia undertook quite a detailed investigative article reporting on the rates of HTLV1. And in turn, that reporting was followed up by a whole lot of public comment and calls for action and public outrage really about this condition that rose quickly to prominence. It was the subject of a First Dog on the Moon cartoon. There were international experts clamouring for Australia to do something. And by late August, the government had found $8 million for a task force to tackle HTLV1 and other bloodborne viruses affecting disproportionately Indigenous communities in Australia. The response to that funding from the Aboriginal community-controlled health organisations who are closest to the HTLV1 problem was, by their own admission, cautious, and particularly a statement from Donna Archie, who's the CEO of the Aboriginal Medical Service Congress, who said, there's been much publicity on this in recent weeks, and now is the time to take stock and carefully consider the issue and an appropriate response. And she's right, now is the time, but that decision came after the funding tranche, and it did happen quickly. The timeline from the media investigation to the funding allocation was just 5 weeks. And I don't know whether HTLV1 is one of the priority health issues in Central Indigenous Australia, but I'm pretty confident that a full comparative analysis of different priorities didn't happen in that time frame, even though research into HTLV1 has been underway for a number of years. So it's clear that resources are needed, obviously, to formulate a public health response, and it's clear that $8 million of funding will go a long way towards that. But I guess the HTLV1 example illustrates how many dizzying and rapidly changing priorities there are for health services, for Indigenous communities, and for decision makers in government. So mulling all of this over, look, I came to this, I'm really hoping to get the best possible report out of our Centre of Research Excellence. I wanted something that was the most compelling, with the best evidence and the best narrative and the most pick-upable cover. But the more I've worked towards that, the more I'm worried that maybe we're all in a bit of a race to the bottom, that we are within our own different disease communities and research areas and focus groups, championing our own causes rather than providing the information that other people need to make decisions, and that we're perhaps too focused sometimes on simplification and media grabs and success stories, and that we're losing nuanced and complicated analysis of really difficult issues. Governments and Indigenous communities need the best available information, and I think public health leadership is providing that to them in a way that's meaningful and useful. So I think that the greatest act of collective public health leadership in Indigenous health, perhaps other than endorsing the Uluru Statement from the Heart, would be to agree and work together on a template for producing information about the effectiveness and proposals for programmatic interventions in Indigenous communities. If we all work towards a standard set of data and presentations and an agreed template, we would improve the quality of information and would be helping other people make their choices rather than lobbying for our own disease-specific interests. I think probably the best example of this in practice at the moment is the Pharmaceutical Benefits Scheme. To become a funded medication in Australia, sponsors need to apply to the Pharmaceutical Benefit Advisory Committee, or PBAC. That's a whole group of experts and some stakeholders who review really detailed applications 3 times a year, which are set out in a really formalised template, and to weigh up a whole lot of information about the burden of the disease, the expected benefits, and a cost-effectiveness analysis. PBAC make their recommendations and they're released in reasonably comprehensible public minutes. I think we could do something for Indigenous health programs. It would mean that those of us who are looking for funds and prioritisation would do more work, but maybe that work would be more valuable. It would mean perhaps that instead of hiring a graphic designer, we would be able to do more analysis of the issues. And so my thinking is that it's not directly comparable. Of course, funding a single drug is much simpler than funding an entire complicated intervention. But there's an opportunity to set up a framework that's at least more useful than the status quo, and potentially offers opportunities for Indigenous and Torres Strait Islander people to imbue their values in that decision-making process. So PBAC obviously has a very strong focus on cost effectiveness, but we could shift that to be about, say, community engagement and equality, and we could respond to those drivers in a collective and cohesive fashion.
Thanks, Rosemary. I'll just ask you to wrap up if you could.
Perfect. So look, we're all embedded actors in this, and we've all got our own areas of focus and interest. I think public health leadership is putting our own research and public health areas of focus aside, and instead providing a system for everybody to work together for a much more common and comparable public health good. Yes.
Thank you, and we'll just give our judges an opportunity to ask their questions now.
Amy, you go first.
I can go first. Thanks, Rosemary. Another great presentation. I really liked how you highlighted the example of the media influence in health issues. And I wonder if you have any examples of how we may utilise the media, first in combating problematic reporting of health issues, but then also in using it to prioritise these key issues once they are collaboratively identified.
Obviously, the media are a critical stakeholder in public debate and dialogue, and these decisions don't happen and shouldn't happen in a vacuum. There's an important role for reporting on health issues. I guess my concern about the role of the media as it stands is that perhaps it's got a pretty hefty voice, and that governments respond to that almost disproportionately to the considered opinion of experts and the people most affected by specific conditions. So I would say that the role of media should be reporting on some of those conversations and obviously facilitating public debate, but I'm not sure that the media should be driving the funding decisions themselves.
Thanks.
Rosemary, thank you. That's a fascinating and thoughtful presentation when you gave way from your own specific sphere of research interest from medical heart disease in Aboriginal population and talk more broadly about examples where perhaps a less than linear and logical process was followed with regard to the cancer risk that you identified. I guess my question to you is, how would you propose the current relatively chaotic decision and policy-making processes that exist within a liberal democratic society to be harnessed in the way that you suggest with regard to your PMAC equivalent process? How are you going to convince health ministers and their senior bureaucracies to see their power into such a process?
I think that's sort of already happening. Minister Hunt has commissioned or identified 10 action areas in health that he wants to develop action plans around. Apparently they all align to the National Chronic Disease Strategic Framework. And he's essentially contracting out development of a roadmap using an agreed template to peak bodies for those conditions. So there's osteoporosis, hemochromatosis, childhood heart disease. So really, Minister Hunt has said, as COAG, as a collective health ministers body, we have identified the priority areas, and we are asking the peak bodies within those sectors to use an increasingly agreed template to provide us with recommendations about what should be done. I think the contrast between what Minister Hunt is doing is really where Minister Wyatt, the Indigenous Minister for Health, is also identified for focus areas, but he's developing his roadmaps within the Department of Health, which means that they're perhaps a little bit less transparent and it's not clear how those processes articulate. So I guess my thinking is that we could not so much say we are, for want of a better word, taking back the power in decision making into public health, so much as offering more packaged up solutions to perhaps a group like COAG by saying, we have all decided that these are the priority areas that need to be addressed in funding for prioritisation applications to this body. And so in order for you to be able to make the best decisions, we as a public health community will be tabling our recommendations in this format with these agreed data standards.
Thank you.
Thanks, Rosemary. Paul, did you have anything to add?
Yeah, another good presentation, and I think all the presentations have been really high quality, so congratulations. I just wonder whether we've done a lot of consultation on establishing health priority areas, and I wonder whether there's a role, whether you think we need more sort of at that end, more emphasis on that end of the system, or whether we should be holding governments and other bodies accountable for the roadmaps they've already produced, and where you think the best effort would lie.
Yeah. Look, I think that's fraught, obviously. Keeping government accountable to what they've already funded and prioritised is, I think, part of our collective mandate as well. Look, I think one of the difficulties with the way roadmaps and recommendations are presented at the moment, particularly those which are developed by NGOs, is that because they're so variable, there's a lot of wiggle room. So governments aren't necessarily pushed into selecting targets which we can then track and report on over time. There's a lot of feasibility and acceptability and a few more infographics. So look, my feeling would be that yes, we need to be encouraging government to do what they've already committed to, but that part of that process is by going in with a much more clearly articulated plan that we can hold them to more firmly in the future.
Fantastic. Thank you. Thanks again, Rosemary. And I'd just like to echo Paul's words there that I've been so impressed with the high quality of our presentations today. So congratulations and thanks to you all. I'm sure that you've put plenty of work into this. So thank you for taking the time to engage with the competition, with the Students and Professionals Committee, and above all, of course, with the PHAA. It's been fantastic to hear all of your ideas today. So we hope that it's been a valuable opportunity for all of you as well. our judges are actually now deliberating on the presentations that we heard today, and they're going to be announcing their winner very soon. You'll hear it live in just a few minutes. But in the meantime, just to give them a chance to do that, I'm going to take the opportunity to share some more information about the PHAA and the Students and Young Professionals in Public Health Committee. So one of our committee members, Tash Reid, has prepared a short presentation. Unfortunately, she wasn't able to be with us today, so I'm just going to play that to you all. My turn to do share screen. And away we go. Okay.
Good morning, everyone, and welcome to the Students and Young Professionals in Public Health Committee Think Tank competition. Today I'll be doing a short presentation on the Public Health Association of Australia and specifically what the Student Committee does. The Public Health Association of Australia is recognised as the principal non-government organisation for public health in Australia and works to promote the health and well-being of all Australians. The association seeks better population health outcomes based on prevention, the social determinants of health and equity principles. Some of the objectives of the Public Health Association are to advocate for reduction in health inequalities, encourage research and promote knowledge, provide a forum for the exchange of views, promote and develop education of workers, promote, maintain and extend special interest groups, branches and affiliations, and promote the excellence in public health practice. The association's mission is to be the leading national peak body for public health representation and advocacy, to drive better health outcomes through increased knowledge, better access and equity, evidence-informed policy and effective population-based practice in public health. The vision for the association is for a healthy region, a healthy nation, and healthy people, living in an equitable society underpinned by a well-functioning ecosystem and healthy environment, improving and promoting health for all. There are a number of branches of the Public Health Association of Australia in every state and territory. They are responsible for advocating for the adoption of PHAA policies within the state and local spheres, applying for the association's policies to local issues and conditions, including assistance in the preparation of submissions at the state, territory and local level, providing local information to the development of PHA policies and holding developmental seminars and workshops. There are also special interest groups within the association, which consist of 17 groups, which you can see on the slide here. And these can be joined at the time of joining or renewing your membership. So the association's members comprise of individuals and agencies or organisations who contribute to the development and implementation of public health policy by bringing their expertise to the development of policies, providing representation on government boards, committees and other decision-making bodies, and providing access to informal and formal professional networks. Benefits of being a student member of the Public Health Association of Australia include early notification of events and student membership prices, access to student scholarships to the annual conference, the mentoring program, student representative positions on executive committees, lots of networking at association events and regular email updates of job vacancies. So the purpose of the association's Students and Young Professionals in Public Health Committee is to represent the interests of students and young professionals within the PHA and to support and enhance the work of the PHAA. The Early Career Student Board position would act as a gateway for students and young professionals to access the knowledge and direction of established public health leaders. They would act as an advisory for and oversee the activities of students and young professionals at a national level, with close links to state branch student and young professional representatives, This would provide opportunities for students and young professionals to further develop their skills and networks in public health and utilise their passion and energy. In this sense, the PHAA can combine their knowledge of public health policy and advocacy with the energy and enthusiasm of younger members through providing them with direction and clear actions. It will also ensure that our future public health leaders are receiving the full support and direction of our association. The objectives of the Students and Young Professionals in Public Health Committee are to develop ideas as how the association can continue to effectively engage students and young professionals, to develop and deliver activities and opportunities for students and young professionals, and to serve students and young professional members of the organisation through implementing initiatives led by students and communications relevant to the committee through InTouch, e-bulletins and the PHAA website and social media. Some of our initiatives include a directory of all student and young professional opportunities, a specific section for our committee on the PHAA website, a national mentoring program and communications specific to students and young professionals. At the moment, we're currently working on student and young professional activities at the Australian Public Health Conference later this year, this think tank competition, and the activities at the Food Futures Conference that has just happened. These are the current committee members, led by Amy Brownbill, who is our chair. And if you'd like to keep in touch with our committee, you can tick the student and young professionals checkbox when joining or renewing your membership, or you can contact us on this email or on Twitter using that handle. Thanks very much, everyone.
Alrighty, thanks to Tash for preparing that for us, and she sends her apologies that she couldn't be here today. So I'd just like to reiterate how pleased we are to be able to offer this competition and the further opportunities that are in the works, especially in our committee's first year of operation, given we were only sort of established late last year. And thanks again to the PHAA for supporting our efforts. We're just about ready to announce our winner for today. So I just want to confirm or reiterate that our winner from today will be going on to present at the Australian Public Health Conference in September in Cairns, and will receive financial support towards their registration and contribute to their flights and accommodation. But as well, all of our finalists who presented today will be receiving a one-year student membership with the PHAA. So we're really pleased to be able to offer that. And I'm sure everyone's just really keen to hear the winner announced. So I might check in with Terry and see if you are about ready to go there, Terry.
I'm happy, and we've been communicating both via the spreadsheet that we've got where we record our scores and also via email. And I've never done this process before, and it's fascinating, but it's good to provide an immediate response. Firstly, congratulations to all of the finalists. You already know that you're in the top 10% in terms of presentations in this competition. It's the first time we've run it. And I would congratulate Amy and Hilary and the team for putting it together. I think it's been a fabulous innovation in and of itself. And using the online vehicle that we've got allows us to do this very efficiently and very quickly. So I've really enjoyed it. It's been it's a tough task to present the complex concepts that each of you have tackled. And so I really do congratulate you all. My one observation is that students covers a wide range of exposure of training within public health, and it's important to understand that. So Olivia, in your example, being an undergraduate, you're in tough competition when you're up against a couple of PhD candidates. So it's important to understand that. There was two very strong, I think the two strongest candidates were both PhD candidates, and they both presented very, very well, and it was a very close call between the two of them. But I think the the judging panel has been unanimous in awarding Rosemary the prize. Simone, you should understand that you came a very close second, so you both should be congratulated. All four of you should be congratulated. You've done an extraordinarily good job, and I look forward to seeing all of you. In fact, I look forward to seeing all 45 of the applicants continue to be involved in public health and take up that mantle as future leaders. It is a great opportunity to be involved in an exercise of this kind, and I'm enthusiastic to ensure it continues. And Rosemary, congratulations to you.
Thanks so much for that, Terry. And congratulations, Rosemary, for that fantastic presentation. And congratulations to you all, and thanks again for coming along today and for engaging with our competition. We hope that you'll all stay in touch with us. Well, we will be in touch with you very shortly, I should say, to organise those memberships, and Rosemary to organise your conference prize. So we'll look forward to being in touch with you. But yeah, just to close, I just want to thank everyone again for making the time and being here today, as well as supporting the activities of our Students and Young Professionals Committee. We're really excited to keep on bringing opportunities like this in the future. So we hope that you'll stay in touch with us.